Just let everyone know that this is being recorded. I just want to welcome Drs. Mitzman and Dr. Boyes. Sorry for a slight delay due to some technical issues, but welcome everyone. And I want to start off by thanking Atricure for hosting this webinar series with the TSRA, looking at various topics. This one specifically today, looking at tips and tricks and other advice that Dr. Boyes and Dr. Mitzman may have for us. All of us that are trying to get to where you guys are in terms of being attendings and starting life as adult surgeons. So I just want to first thank both of you also for being here and taking the time to do this tonight. Do you want to start off maybe by introducing yourselves, maybe where you were in training and kind of where you are now and what your day-to-day looks like?
Sure. So I am Brian Mitzman. I'm an assistant professor at the University of Utah and the director of robotic thoracic surgery. I did my fellowship at University of Chicago and graduated in 2018. This is my second position. I left my first attending job after my first 2 years and moved out here last summer. Just happy to be here. Hopefully can share some advice with all you guys. And, you know, the time goes by fast. You'll be done, you know, before you know it.
We sure hope so. And Dr. Boyes?
Yeah, thanks, Dr. Weiler. So I graduated in 2019 from University of Virginia, Thoracic Surgery Fellowship, and I took my first position out at the University of California, San Diego, doing thoracic surgery. And so far, I have stayed in my first position. It's been great so far.
I realize it's kind of a blessing when that does work out that way. I know the first job can be a little difficult at times. So thank you both again for being here. I guess we'll jump right into questions, and I'll just say ahead of time to all the participants that we do plan on leaving time at the end for questions. Hopefully we'll touch on whatever questions you have, but if you do have questions that aren't discussed, please feel free to post them in the chat and we'll make sure to touch on them. So Dr. Boyes, I guess we'll start with you. When and where, or how I should say, did you start the process of looking for a job in terms of timing in your fellowship and how far out you looked and what resources maybe that came in handy?
Yeah, well, I think, you know, as we go into cardiothoracic fellowship, I think we've all already kind of been laying a groundwork of, you know, where we want to go and what we want to do and some idea of the job we would like. And so for me, I grew up in Southern California and I've been educated all throughout the nation. So on a personal level, I knew that I would want to move my way back to the West Coast. And, you know, my mentors at University of Virginia were phenomenal. And really what it was is in my first year, just reaching out to people and meeting people at national meetings, STS and AATS and other meetings that, you know, just saying hi. I know you don't have a position now. I'm not even looking for a position now, but, you know, keep me in mind when things are coming up. And so really even in that first year, just kind of reaching out and making connections and being open and honest with your mentors too, because, you know, the community becomes smaller and smaller as you go through your training. And so they're also able to say, hey, you know, my friend here or my friend there, like you should at least talk to them. They may not have a job, but maybe they know somebody. And so it's really early on that, you know, you start building that network. And, you know, for instance, a very real experience for me, I went to a national meeting. One of my mentors set me up with Dr. Onitis, who is here. And so, you know, we met informally at a meeting and we just kind of chatted about what my goals were and what the program was like here and where it was going. And then, you know, as time went through, you know, a position did open up and it ended up working out for us. But at the beginning, there wasn't a job. And so, but making those connections early on obviously went a long way for me.
Mm-hmm. That's awesome. And what about you, Dr. Mitzman?
Yeah, pretty much everything that Josh said. The big thing is that, especially for academics, most academic junior jobs are not advertised. They are never posted. It's kind of, they're talked about offline between program directors and chiefs. And it's really important for your mentors and your program director to make phone calls on your behalf, or for you to personally just make those connections and just call people and say, hey, I'm really interested in going back to Southern California like Josh did. If you ever have a position, keep me in mind. And, you may go through a whole interview process and no one else will even know that those interviews are even happening. So it's important just to put yourself out there and, make those connections.
So cold calling is not against the rules, or I guess cold emailing in
Yeah, you
this
got
day
to
and
do
age.
it.
Okay. Okay.
So when I was graduating from fellowship, my program director said, give me a list of 30 hospitals you could see yourself
Wow.
working at. And at the time I really wanted to be in the Northeast. So I did, I put together a list of, 30 hospitals that kind of had what I wanted, the right kind of region, the right mix of, academics and clinical. And he personally sent an email to the chief of every one of those hospitals and said, hey, I have a graduating fellow. Do you have an opening? And I think I got 5 interviews based on that. And those were positions that had never been advertised.
So it sounds like from both of you, having the right mentors is key in this process, because doing it on your own probably may not be as easy as if you have someone rooting for you or kind of opening some of those doors for you.
Mhm.
Okay, well, along those lines, when you do find a place or a few places that you're looking at, you've narrowed things down, have you found a good way to get the real scoop on an institution? So everything may look great on paper, but you don't know, am I going to have the support they're promising? Am I going to have the block time or whatever? What is the culture at the institution? Is there something you found that's actually very helpful in getting that information?
I guess I could start with this one. I think the big thing is most places will promise you the world. You need to find somebody that's unbiased. So, hopefully the fellows and the junior faculty that are there will be honest with you, but, many times they're just looking, to get an extra set of hands and to get a partner as well. Try to find somebody who used to be at the institution, whether they're a fellow that graduated or, a faculty member that's moved on for better or for worse, and get their opinion. No one wants to burn bridges, but hopefully they'll be honest with you about what it's really like to work or to train there.
I would agree with that completely. If there's been someone who's left recently, try and get in touch with them if you can. I think they can give you a good inside scoop. And those things range from a gamut of, personal reasons to professional reasons. And so those are good things. Oftentimes too, again, your mentors know the people there. They know, if they're going to help you foster a career that, you want. And then one that's kind of interesting, I never really thought about, but it happened serendipitously, is that actually reps know each other from all over, and they're actually in the OR with a lot of these people and know them on a personal level. And it's kind of this one-off, like, hey, what do you think about, how are things there? And it's a little bit of that third person party view that can sometimes give you a little bit of information. I mean, I wouldn't stake everything on it, but it may give you another look if you have that connection or someone that you can trust.
Okay.
That's
And I
actually,
guess, sorry, go ahead.
And that's actually really important too. So, for example, if you're interested in general thoracic and you want to do robotics, Intuitive pretty much knows about every single opening across the country before, they're ever advertised or people are talking about it, because most people will go to their Intuitive reps and say, hey, I need somebody who is robotically trained, who's graduating, that's good, that has a good reputation. So yeah, totally talk to the reps.
That's a good point, because our rep actually recently said that. He was like, when you start looking for jobs, reach out to us, because we do have some sort of inner network for the job search. So that's a very helpful point. Are there any red flags? So is there anything that someone may say or promise you or not mention that if it does happen, you should be your antenna should go up?
You want to jump on this one first, Josh?
Yeah, I think, kind of along the same lines, if they have a hard time keeping people at an institution, or there's a lot of turnover, that's something, again, the reasons for people leaving run the gamut, better opportunities or personal reasons. So you kind of have to think through it a little bit. That's probably the biggest thing, I think. And then, some of the other little nuances, especially in academics, are people getting to where they want to be in their career, or, how are things weighted within the department and division, and kind of look and see, if that's a place that you can grow and feel supported. And some of those things are not an obvious red flag, but, those are some things that might kind of jump out at you as you see multiple programs.
Okay.
Yeah, no, he's spot on. I could talk about this all day, this specific question. I left my first job after 2 years because it wasn't the right fit. But I learned a lot, so when you're coming out of fellowship, this is your first job. We're used to being in a match system where basically you're told you're going here, period. No negotiating power, take it or leave it. And really there's no leaving it. So subconsciously, we're kind of trained to look past red flags and just go with the flow. But this is the first time where you shouldn't do that, because your first job is probably the most important thing when it comes to your long-term career. So like Josh said, what's the track record been in the department for junior faculty? Does every junior partner leave after 2 years, or do people actually stay on? If it's a smaller practice, have there been partners before? Has the senior guy always been by himself? Or has he mentored people and have had, or has she mentored people and have had, partners in the past? Especially if you're going into academics, when you interview, are you interviewing with just the surgeons? Or are you also interviewing with the pulmonologist, the radiation oncologist, the oncologist, everyone that you would work with, where, all these multidisciplinary people have a say in who's getting hired into the surgical department? That's a big sign that it really is a multidisciplinary group. If you're cardiac, are you meeting with the cardiologists and, the interventional team? Do they actually have a plan for you? So they're saying, oh, we have all this volume, we can't wait to get you. Where is that volume coming from? Are they opening a new hospital? Is somebody retiring? Do they have a specific plan of where your volume is going to come from? And it's not just show up and, we'll figure it out. Reimbursement structure. So this is a big red flag. Are you being set up to compete against your partners? Are you going to be RVU based, where your bonus is based on your personal case volume for the year, where even though you're the junior guy and they're guaranteeing you a salary for 2 years and they're promising you X, Y, and Z, you are still going to be competing with your partner for every case, because each of your paychecks completely depend on it. I can go on and on and on, but those are the big things in my mind.
Okay. So along those lines, I guess, in the job search, let's say, especially in the era of COVID, where we haven't had kind of the benefit of the in-person meetings, we are taking what we can get as far as what's being posted. And if you're at an institution where you maybe don't have that type of mentorship, is it worth saying, all right, this job is out there, it's not really what I'm looking for, but it's either take this job or maybe consider spending some more time in training? Any thoughts on that? Or do you think that it's just something you should avoid, and just take the risk and see what happens? Or is it really just a case-by-case basis?
It all depends on what you're looking for. There's no perfect job. You could wait a decade, you're not going to find the perfect job. It just doesn't exist. But you need to find something that can get you where you want to be and where, you're going to be happy. If it's a job where, it's not perfect, but you'll get good mentorship. If you want to do research, they'll support your research. You'll get case volume. Even if you can only see yourself there for a few years, as long as you can advance your career, you can tough it out for a few years. If you're going to basically be doing, scud and acting like a medical student, for 2 years as an attending, it's not worth it. That said, doing a super fellowship for a year, there's no guarantee that in a year there's going to be more jobs. You'll have an edge up on other applicants coming right out of fellowship, hopefully, and you'll have had new connections. But again, there's no guarantee that there's going to be more job openings. So it's a risk.
Okay.
Yeah, I think in the era of COVID too, it's very much a tailored approach. And everybody has, some order in their life of the things that are important to them. And so it's really important that you know what is going to make that career work for you. And some people it's location, geography for personal reasons. Some it's all professional. I think you have to be honest with yourself, and it's okay if those things change or, have changed throughout your life cycle as a trainee too.
Mhm.
And so I think that's one thing. And so knowing that first is probably going to help guide you where you want to be. I will say that I think it's very important that you continue to get a lot of reps in your early practice, because it's just different going from fellowship to being the attending. And so you want to stay busy doing things in a place that you'll have some protection and mentorship. And so for me personally, like if I didn't see the job that was like everything that I wanted, but those would be the most important things, because you're looking for, a 20-30 year career, and those first couple of years are going to be really important to have a situation where you can actually get more reps. And I think if you do a super fellowship, you just have to be aware about it. Not all of them are the same, and you have to be a little bit thoughtful about it. I think in the era of COVID, I mean, everybody put a hiring freeze down, more or less.
Mhm.
And so that extra fellowship year sometimes is not just extra training. It's kind of like a job interview, and if they like you, then hey, that job is going to become available.
Yeah.
And so those aren't guarantees, but sometimes those are things that especially with, again, COVID, just it's not the same. And so those are some of the things that can happen. And I think if you need that extra year of fellowship too, and you think that you're going to be able to be more marketable and come out and be the guy at a place, then that also brings value. And so I think going out just to take a job to make money, or just to be not in training, is probably not the right answer for most of us. We've worked really hard to get here, and then to not be successful. And I think it's easier than you might think to not be successful if you don't have the right environment. In my opinion, I feel very fortunate here, but I could see, like, as I interviewed a bunch of places, and I would recommend you interview as many places as you can, how certain scenarios, if I had ended up there, would not have been as good for my growth. And so
Okay.
I think another big thing is if you want to do academics and the only job you could find is private practice, should you take the private practice job for a couple of years and try to switch over?
Mhm.
And it's very possible to do, but what you have to keep in mind is, like Josh said, during those first couple of years, you need to get a ton of reps, get comfortable in the OR, and basically learn how to operate as an attending. But if you want to make that switch back to academics, you're also going to have to do research and be academically productive in those first 2 years. And if you're in a pure private practice job that doesn't give you those kind of that academic and research support, it's going to be very hard to do. You're going to be doing a lot of it on your own. And then before you know it, 2 years is up, you're ready to look for, make your switch, and your CV hasn't changed at all. Yes, you're more comfortable in the OR, but you haven't done a single paper, and,
Mhm.
you haven't made any new academic connections.
Yeah.
So lots of things to keep in mind.
Yeah, that's very helpful. So you have both touched a little bit on the topic of money and payment and contracts, I guess, leading into that. The big question I think a lot of people have is negotiating. How do you do it? Do you get an attorney? Do you just have your mentors look over your contracts? And two, when or if do you talk about money for your first job? And I'll start with Dr. Boyce for this one.
and this plays into, I think, seeing as many places as you can. And even if you want to do academics, you should probably go look at some private practice jobs.
Mhm.
Because I got to be honest, all the places I went to interview, they each had some slight different model of advancement or partnership, or how things are reimbursed, RVU models, collections, and those things are constantly changing. And so as a trainee, there's like a lot of things you don't even know that you don't know. And as they talk about it, and you should bring it up, and you don't have to in the goal in the first interview is not to talk about the number. The goal is to talk about how, like how does it work? How do you guys decide what it is? And that's probably in my opinion, the bigger question, because you're not going to come out and be the busiest surgeon most likely, but you want to know that if you work hard and you do these things, like how are these things, if it's in academics, the academic side, the education side, the research side, and then the clinical side, how do all those components fit into a compensation package? So you really want to know the nuts and bolts of how those things play together. I think as that's the first look at an institution. If you're very serious about it, then that second conversation can be, what does that actually look like? And I think one of the interesting things I found is in the academics, or like in private practice, they would oftentimes send you an offer letter, which would kind of give you a thumbnail sketch of what that is. But in academics, it wasn't always, it was more of a verbal, discussion. And so it's important, but I think the nuts and bolts on how those compensation packages are put together is more important than the value is important, but those are some of the things that you need to decipher, and you'll see that they're all very different.
Okay. Dr. Mitzman?
Yeah, I think a lot of it starts with self-education, because we're not taught this in fellowship. So before you guys graduate, sit down with your attendings, especially the junior faculty, and have them teach you, what are professional fees? What does a CPT code reimburse? What is a DRG? How does the hospital make money? And then all the different payment schemes for surgeons are, what's an RVU-based system? Is, what does pure salary actually mean nowadays? What's a normal base RVU that, a surgeon is expected to shoot for? I think one of the things that we've done to ourselves is everyone is afraid to talk hard numbers, which is just stupid. It only hurts ourselves. I think we should be very open with each other, about what we're making. So, to give you an example, talk to junior faculty, talk to graduating fellows, see what kind of offers they're getting. I mentor a lot of people that are looking for jobs. And from what I've seen in the last couple of years, most academic jobs, pure academic this is for general thoracic. I have no idea what cardiac is. Most pure academic jobs at universities are starting anywhere from $325 to $375 a year. Know what the MGMA data shows. The MGMA data tells you the different percentile ranges for all surgeons around the country based on specialty, how many RVUs they're doing, and what they're getting reimbursed. So know what that is when you go into your negotiations with the hospital. If you're looking at private practice, you can probably expect a higher starting salary, somewhere in the $425 to $450 plus range starting. Those are offers I've seen in the last year that people are getting right out of fellowship. Moving expenses should be covered. Don't let any hospital, university, or private practice tell you that it's not standard. Your moving expenses wherever you're going should be covered, and that should be negotiated in. Signing bonuses are also common. You should be able to negotiate, a decent chunk of money just to sign on. Tuition reimbursement is common. Don't let anyone tell you can't ask for these things. If a hospital wants you, you can ask for it, and the worst they can do is say no, but they're not going to pull the offer because you're asking for things that are reasonable that everyone else is getting.
That's really helpful. Thank you. Thank you both. So I guess along the lines of contrast, we all kind of have a vision as you go through fellowship of what you think you want to focus on. I really love transplant, or I really love, general thoracic or foregut. But you find a hospital or a group that you really like, and they want you to spend more time with one versus the other. How do you kind of balance negotiating that in the sense of, I don't want to lose this opportunity, but I also don't want to spend 70% of my time doing lung transplant when my first love is, lobectomies or something? Any thoughts, Dr. Mitzman, and then we'll go to Dr. Boyce.
Sure. I think it's really important. I'm a big believer that it's very hard to be, a full-time transplant guy and also be doing a lot of thoracic oncology. It's very hard to balance. Most academic thoracic jobs are going to involve some element of transplant. That's a given, but it shouldn't be 70% of your practice if it's not what you're interested in. This kind of goes back to picking the right first job. you can't take a job based on region or how much you love, the hospital, if you're not going to get to do what you want to do. There was a hospital that I loved and I would have loved to go back there. And they had a position a few years ago that, it was mostly transplant, which was not what I wanted to do. And I turned it down because then I wouldn't be getting the reps in thoracic oncology and doing the cases I really wanted to do. And when it was time to, say, move on to another institution, I wouldn't have the CV or the skill set to sell myself. It's a balance. You have to really see how much you're going to get to do that you want and how much is just, the other stuff that they need you to do.
Dr.
I
Boyce.
agree. Yeah, I mean, I think you got to be honest with yourself and with your people who want to join the team, because particularly in those situations you're on the team and working in a group. But if the job is for one thing and that's not the thing you want to do, then it's going to be a problem, because it's not going to live up to your expectations and you're not going to live up to their expectations, or you will and you're not going to be happy. And so I think really long and hard about that. Now, if they say there's a plan in place for XYZ, depending on where it's coming from and if that's a reality, you take those things with a grain of salt, but you can only take things at face value for what they are when they're there, what's going on when you're there, and don't expect too much different, when you show up.
Mhm.
And if it changes, that's great. But if not, then don't be disappointed, and really take each position as how it is. And I think if they're saying we really need someone to do this, then that's probably true. And so you should either settle with being that person or maybe look for something else, because it's not fair to you, and then it's also not fair to the job.
Yeah. Okay, so we've interviewed, we've signed our contracts, we're happy with our pay, we show up day one, and life is X. What would you say was your maybe rude awakening or pleasant surprise in your first couple months of being an attending? I've heard it being described as going at 90 miles an hour as a fellow, and then being told to drive at 30 because you're building your case volume or you don't have the skills or the support. What was your transition like, Dr. Boyce, and how would you say to maybe prepare ourselves for that?
Yeah, so in our practice, we have the main university hospital, then there's also kind of like this wheel and spoke model. And so, at the university, it was very much, I grew up in academic settings, so it was very much, the relative, interns, residents, fellows, and attending. And we get that at the university, but then, at these other hospitals, you're like, okay, well, I guess I'll pull the chest tube, And so it's not bad. It just is what it is. And, we all know we're all capable, but, it can happen, and that's different. It's not a bad thing. It's just one of those changes that you've kind of been groomed through academic training your whole time. But I knew that coming in, so that wasn't like really a shock to me. It's just an adjustment. And then also having, patients at, operating at two places and having patients in two, you have to be a good time manager and learn to, deal with that. And it's a little bit of a different, you're used to having kind of patients in one spot, and that's your team, that's your floor. So that was one thing. And then the other transition is just, you carry the full weight of all the decisions that are made. And so while you grow, it's always great to have a support system around you. Feel free to call your old mentors, use your new mentors, really lean on people. And so hopefully in your training, you've had some of those experiences where you've had that autonomy to make decisions and kind of own some decisions, but it hits different, when you're the guy. And there's so much training that you feel prepared for from a technical standpoint, the right answers and this and that, but it's different, the stress is a little bit different. And then the one thing to always tell yourself is that you're trying to build case volumes, but you shouldn't, you really want to like, okay, I'm putting cases on and I'm doing, big cases, but you don't want to skip steps too, continue to do the right things. And so you always have to remind yourself that, do the right things, pre-op the patient appropriately, get good results, and the results will speak for themselves, and then, the referrals will come.
Mhm.
So sometimes you want to go, 100 miles an hour, like in fellowship, but you need to, you need to like make sure you're doing the right thing and lining things up so you have good quality, and the rest will come.
Mhm. Okay, Dr. Mitzman?
Yeah, just to kind of talk vaguely a little bit. It's there's going to be some element of shadowing in your first few months. It's going to feel like you're not really an attending, and that's okay. You're in a new institution. You're learning how things run. You're learning how your partners do things who may have been there for years and years. They're learning, how you do things, and if and how to trust you. You're going to be helping them with their cases. You're going to be assisting. You may feel like you're doing a little more floor work than normal, and that's all okay. But the big thing is there should be a very clear pathway on how you become an independent attending. How are you going to build your own referral base? How are you going to get your own cases? You shouldn't just be cleaning up after your partners and covering them and covering all of the call. That's not what it's supposed to be. And if you're 3 or 4 months in and that's still going on, that's a problem, and you need to reflect on why that is still happening. But like Josh said, the first few months you're going to expect to be going at like 30%, not 100%. You're going to be going slower. Enjoy that free time. If you want to do research, use it to network and to start laying the groundwork to build up some research projects. And just take the time to, again, just absorb everything and really see how things are done at your new hospital and get good outcomes and get people to trust you and build up your reputation.
Dr. Boyce, you touched on something that, I think we all think about as trainees when you're in the operating room with this attending and you're like, I'm going to do this case. I'm going to make the incision. I'm going to do the dissection, blah, blah, blah. But as the new attending, speaking to outcomes and having things look good before you're established, as you establish yourself, how much are you letting residents do and trainees do? And how much should you kind of make yourself prove to yourself that you're comfortable doing a case before you're allowing residents and trainees to take more of the case on?
Well, that'll be different for everybody. I think we've all, through our training, whether it's integrated or general surgery, traditional pathways, we all been in that situation where there's a new attending and you're the trainee. And just like throughout other aspects of training, those types of responsibilities and technical privileges in the OR are earned. And so early on, I think my fellows knew that we would do the case together, but I was going to get some reps in doing the case. And I remember when I was a fellow and we had a new attending, and that's what they told me. And I think we all understand it because it's not too long until it just keeps flipping, and then that fellow is going to be the attending. They're going to need to do that. Some of that's like self-proving, but it also depends on the case. A peripheral wedge resection, for a second year cardiothoracic fellow, yeah, I'll probably just like sit back and be the assist, and let them run the show, and so it depends. But if they do good with that, I have a very thoughtful way, like for a robotic lobectomy, for a first year fellow, okay, like this is where we put the ports. They put the ports in next time. Inferior pulmonary ligament, no dissection, vein, then bronchus, then PA, and and they have to earn those steps along the way, and they don't all move at the same speed.
Mm-hmm.
But I did a lingular sparing left upper lobe the other day, and I let the graduating fellow do 95% of it, and so you can get there, and it really depends on that rapport you build with the fellows and their skill set and instilling that.
Dr. Mitzman?
Yeah, so it's a tricky question. In my first position right out of fellowship, I mostly operated at an affiliate hospital. I didn't have fellows, so I didn't really have to worry about that. But I think that now I have a fellow and a resident every single case. But I'm obviously, almost 3 years in and past that learning curve. I think it's important to know yourself and to know the first few months, you should probably be doing almost everything and really getting those reps. And most fellows and trainees will understand this. I think it's all about expectations, letting, the trainee know at the beginning of the case, hey, I need to do this case skin to skin. I'm not ready yet to pass it over. It's my first week being an attending, and, I'm doing an extrapleural pneumonectomy. You're not doing this. I'm sorry. It's just, lay it out there. Be honest with your trainees about what your own personal comfort level is and what they can expect to do with the cases. But especially if you're going to be academic and you want to teach, there is going to come a point where you're going to have to develop that thoughtful process of how you, teach your trainees and how you hand over the cases. It may take a few months for you to get there. It may take a year, but you're going to have to get there if you want to be in a teaching institution.
Yeah, very true. So I wanted to circle back again to finances, but kind of in a different form. When we talk about being at an academic institution and doing research, is there anything you found that was helpful in finding funding to support, whether it's specific projects you wanted to do or just to support your salary if that was required at your institution? And Dr. Mitzman, I'll start with you on this one.
So I think this also ties into red flags a little bit. If you're going somewhere and they're verbally telling you, we want you to do research, we'll give you X, we'll give you Y, we'll give you Z, you'll get a coordinator, you'll get research time. But then you ask them to put it into your contract and they say no, that's a big red flag. If it's not on paper, you don't know if you're ever going to get it. So when it comes to funding, the big thing is if you really are expecting to apply for a K grant one day or eventually be the kind of surgeon that tries to get an R01 at some point in your career, you need dedicated research time. It can't be just nights and weekends. If you're going to an academic institution and you want to do research and they're expecting you to do research, you should have a day a week where you are protected and you could focus on that research. Because before you're able to apply for big grants, you need to get prelim data. You need to do projects. You need to build your network. You need to get publications out there. And you're just not going to be able to do that if you're expected to do clinic and operate, 5 days a week. It just doesn't happen. The people that tell you, oh, you don't need dedicated research time are the people that don't have funding and don't know what it takes to get it. So you need to make it an actual part of your practice, and there has to be division or department buy-in that they're going to give you that backing. Many departments will give you a research stipend. So if you really want to be part of your practice and there's real buy-in for research in your department, part of your contract will be $50,000 or $100,000 research stipend to help get your research off the ground, to get you that prelim data so you could apply for your NIH grant down the road.
Okay.
I agree with that, 100%. I think those are words of wisdom from hearing from what your department wants from you. I think some of the other things too to think through are, if you have a VA, there's some VA grants that you're easily accessible to, or you have a higher percentage chance of getting. Then through, AATS, STS, there's early investigator awards. And so there's a lot of things out there, even within our own university, through our cancer center, there's, institutional grants that can be applied for with varying amounts. And so there's a lot of funding out there. A lot of it has to do with reaching out to the right people and finding what those things are available to you. Mm-hmm. I think, what Brian's saying about the support of the department is 100% true. In what they value and what they want from you. There should be support there, and then depending on what career you want, you can pursue those things.
Yeah. Okay, and we're coming up on 15 minutes left, so I just want to remind our attendees that if you do have questions, please post them in the chat and I'll make sure to incorporate them into the end of our hour here. But so similarly, but more related to personal life when it comes to finances, did you guys get financial advisors? Did you have them? And disability insurance, was that something that you got during fellowship or waited until you were attendings? And were there any tools that you found to be very helpful in learning how to manage your finances as new faculty? Because obviously your lifestyle and kind of income changes in that transition. Dr. Boyes, I'll send the ball back to you.
Yeah, well, I'll answer the first one, or the disability one's easier. I actually had disability insurance after my third year of general surgery training because we could moonlight. And so in my mind, I thought, well, at this point, I can actually, if the world fell apart, I could do some moonlighting here and there and make a living, and so that was the point at which I picked it up. It wasn't a lot, but it was something. And so I've carried that through. And there could be a whole topic on disability insurance in and of itself, but you do some homework on it before you just go out and get one. And then usually whatever institution you're with will have some sort of various levels of disability or mortality benefits and things like that. So you'll want to do a little bit of homework and see what that's about. But really, my opinion is once you feel like you can make a living doing this, you should probably have some coverage for yourself.
Okay.
On the financial advisor side, I mean, it's just different. The physician world is just different. And thank God there's so many different, blogs out there now and other resources on the web. I'd say just try and read and educate yourself as much as possible. And use the people, so whatever company or institution you end up with, they usually have one of the major, brokerage firms, and they usually offer you, retirement advice and have like personal people you can talk to. And just, I would say early on, take those moments to really talk to them and figure it out and think through it. And everybody's life situation is different. And so you're going to need to come up with a plan, and those plans will change to some degree, but you want to do it early and have kind of a thumbnail sketch. And some institutions have different opportunities. Some are similar to like a pension, and some have these different savings, 403Bs and 457s and education. There's so many different vehicles out there now, and you need to talk to someone who knows what those vehicles are. And so I think having a financial advisor, you don't necessarily have to pay for one. Oftentimes your institution provides that for you, but it's, early on, it can be useful to think through things and see, and get some education for yourself.
Okay, thank you.
Yeah.
Dr. Mitzman.
He hit most of the major points. Disability, you should buy your own private policy. You should get it while you're a trainee. If you get it while you're still in training, there's usually a permanent discount that you get for the rest of your life. So, if you can get the money together, get a policy early, and you could always up, the monthly reimbursement down the road, and which will increase your premium when you're able to afford it. In regards to, what happens when you graduate, you get that job and your paycheck has that extra zero on it. Obviously just know yourself, know your own finances. If you have student loans, make sure you're paying them back reasonably. If they're at a high interest rate, consolidate. Things are a little tricky right now just because the federal loans, are at 0% and no one really knows when they're going to go back to normal or what's going to happen with them. But if they go back up to 7%, look into consolidating. Don't let anyone tell you not to live your life. You're allowed to splurge. You've trained for the last decade. You want to go buy a new car, go buy that new car. Enjoy yourself. Be reasonable though. You want to buy a house, buy a house. Just don't be house poor. A lot of you will probably have families by that point, and enjoy being an adult. Just be reasonable about it and know what your overall finances look like.
One thing that came to mind as you guys were talking, that's extremely helpful advice that you both touched on there. But looping back to kind of that early part of your practice, are there any cases you wish you had done more of that you found yourself in the operating room as an attending and you're like, man, I should have actually gotten my hands in there a little bit more when Dr. X did, this procedure?
do everything you can.
Okay.
Even if you only see a case once, that's one time that you've seen it and you're going to remember it. A lot of it is just learning the basic skills and the basic techniques so you could put them together when you need to. You may never see how to do, a robotic Morgagni hernia, for example. I did one of those this morning. But if you know the general principles of robotics, plus the principles of how to fix diaphragmatic hernia and reducing the sac and, the kind of stitches to use on a diaphragm, you could put all those skills together. So yeah, you can do a robotic Morgagni hernia. And that's what a lot of your first few years as an attending is going to be. You may not have seen a case, but you have the basic skills to put it together and be able to do it. And then hopefully you have a senior partner who has done it and, who could be your backup and who can give you, tips and tricks if you need it.
I agree with that. And one additional thing is, as you look for jobs, you never know what kind of ancillary support or other, colleagues you're going to have. So, if you train somewhere where like interventional pulmonology is really strong, and maybe you're not seeing, a lot of EVIS, but then you are looking at a job and there's no interventional pulmonology, then, okay, do you want to be picking that up while you're out there? Or maybe, go hang out with the interventional pulmonologist if you have a slow day or something like that, so try to be thoughtful about the strengths and weaknesses of where you're training. And if you think you may need something else, if you were to go be the only, thoracic person there, at least get a look at it. So it's not the first time when you get out there. And, I think that's probably the bigger key. The real answer is what Brian said, is do everything you can. And, just it's your time to do it as much as you can, wear yourself out, see as much as you can, be on the case as much as you can, do as much as you can. So, but that's a way to just kind of think through what the strengths and weaknesses are your training program. And if there's something that isn't there, then maybe try and seek that out.
Okay. I have some friends that have completed the interview process, have signed their contracts, and one of the things they shared with me is that the request for robotic skills has been increased significantly and was a common thing on their interview trail. Is there anything else that people should make sure they, try to get their skills improved on as they're along the same lines of the last question, but robotics seems like a big one. Is there anything else you guys have found that you think would be really helpful for new graduates?
Don't neglect your other skills. Robotics, yes, it's very important in the thoracic world right now. Every hospital wants a robotic thoracic surgeon. Make sure you can do a thoracotomy. Make sure you know how to do an open lobe and how to bail yourself out of any robotic case. Don't neglect, your foregut. You may be at a training center where Gen Surg handles most of the foregut stuff, but in many places around the country, it's still thoracic surgery that does it. We do it here, and some of my favorite cases. VATS is still an important skill set. Even if you're a robotic surgeon, I'm a big believer that you need to be facile with VATS instruments and be able to do a VATS lobe comfortably. Mediastinoscopy. Yeah, you don't do that many anymore, but I've done 4 in the last 2 weeks. We just got hit with a wave of them for, patients where EBUS was inconclusive. So make sure you're comfortable doing a med. Yeah, be comfortable with everything. Easy to say now.
I think robot is kind of still the hot thing that people want. And, also hospitals buy this robot now and they're like, we need people to use this robot to make it worthwhile. So that may be part of it too.
Yeah.
But really you're putting tools in your quiver and arrows in your quiver about tools in your tool belt to deal with multiple problems, because you'll see things you're like, wow, I've never even thought this problem would be a thing or in this particular type of patient. So you want to have all the tools you can have to deal with that. I think the robot is attractive from a marketing standpoint and good to have, but definitely from going out and being a competent thoracic surgeon that can be a good partner and a good colleague, you're going to want all the pieces to the puzzle.
And robotics specifically, there's very few training programs where the fellows will come out and feel comfortable doing a robotic lobe skin to skin. you may have the double ATS Graham Fellowship and have that training and have the fancy certificate. But, be honest with yourself. If you're taking a job where you are going to be the only robotics person, your senior mentor is not a robotics guy and they're expecting you to build a robotics program, really know what you're capable of doing and what kind of support you're going to need. Reach out to Intuitive. They have great programs for junior faculty to get you linked up with proctors across the country that can help you get going in a safe manner. Reach out to me, reach out to Josh, reach out to other people that have been out for a few years and are doing robotics. We proctor people, we teach people. There's a lot of us out there that will help you. But don't promise, a hospital that you're going to be the robotics expert with no support if you really are not able to do that on day one, because not only are they in it for a rude awakening, but you are too.
Yeah, that's true. So we're coming up on 5 minutes left. I'm going to ask, I don't see any questions in the chat. So I'm going to ask kind of a global reflective question of both of you. And I'll start with you, Dr. Boyes. If you guys could just touch on kind of the biggest challenge maybe in any area, whether it's personal life, work life, with becoming a new faculty that you've encountered that maybe was a surprise. And along those lines, if you could go back to your, senior fellow or even first month out of fellowship self and give yourself a few pearls of wisdom, what would that be? So kind of two questions, but along the same lines.
Yeah, I don't know. It's just been such an odd transition with the COVID situation for me in my first, year and a half. So, but
Come
there's a
on,
lot
bare
of
your soul with us, Josh.
yeah. There's a lot of firsts for me. New job, new city, had a kid. It was a lot, and so for me, it was probably more of a personal thing. Really, just making that jump to being an attending with so many other firsts going on, and then you go to the pandemic on board with that, and things change, and so what would I go back? I mean, there's probably nothing in training because it's more of a personal thing. I think communication is probably the biggest thing. Just keep communicating with your significant other, and those are the things that I think have helped me out the most, is just continue to communicate and be a good communicator, whether it's in the OR. It's okay to ask for help or to get an opinion, ask your partners to look at a case and say, hey, this is what I'm thinking. Am I looking at this right? And it's okay. You don't have to come out and have all the answers, and it's okay, and that's what they're there for. And that's, everybody's been in your shoes, and just keep telling yourself that, and slowly but surely over those first 3 months, you're like, okay, like, yeah, it's going to be fine,
Okay. Dr. Mitzman.
Yeah. So, I left my first job after 2 years. It wasn't the right fit for me. I thought it was going to be perfect. It was the region that I wanted to be in, but I wasn't getting the mentorship I needed, and I wasn't growing. I wasn't going to be able to get to where I wanted to be. And that was hard to come to grips with. It was very hard for me to realize that this is not okay, and I need to move on. I can't just keep waiting year after year for things to get better when they're not going to be getting better. Again, it was really hard to convince myself that it wasn't me and that it's just not working. I had a handful of mentors telling me, you can't leave your first job within 5 years. Do not leave your first job before you hit that 5-year mark. That's total BS. Don't ever feel that you are trapped. If you're a good surgeon and you have a good background, you will be fine. And the longer you stay in a job that's not advancing your career, not giving you the mentorship you need and helping you grow, the more unhappy you're going to be, the worse your CV is going to look, and the harder it's going to be for you to find another job down the road. So you have to be, honest with yourself. And I wish I had actually realized it sooner. But everything works out for a reason. I'm thrilled where I am now. And, the first job is not likely going to be your last. What do they say? 80% of people leave their first job, within 5 years or something. It's not common to stay on forever in the same place.
That's really helpful advice. We have a couple minutes left, and I don't want to leave without making sure we've gotten everything you guys wanted to share. So is there anything we haven't touched on that either one of you want to make sure you highlight, or, maybe you want to go back to? And I'll start with you, Dr. Mitzman. Maybe.
We covered a lot.
Yes, we did.
You know, I think one of the important things is, your program director is going to be a resource for you for the rest of your career. There's someone you're always going to be able to go back to and ask questions about cases. If you need to make a career switch and switch jobs, they can always give you a recommendation and help you network. So don't lose that relationship. Stay in touch with the people that are training you and that you trust. Dr. Ferguson was my program director at U Chicago. I still talk to him every couple of weeks and ask him what he thinks about cases. And I brag to him about interesting stuff that I'm doing. And I ask him about research projects. I have amazing mentorship here in Utah. I have Tom Varghese here, but I still talk to Ferguson all the time. And I really highly recommend that you guys do that too. Don't forget the people that trained you and that spent years with you and know you, because they're going to be with you for the rest of your career.
It's really true. And Dr. Boyce?
I agree. I mean, that mentorship, from the past and the present, and, there will be people probably in the future that, you met previously, but they can really help you out. And so 100% mentorship and being in an environment where you're going to grow is really important. And so you have to be honest with yourself and honest with your mentors so they can help you get to those places that you want to go. We've been through a lot of training to, not be in a place that you want to be for a career. And so I think being honest with yourself is really important. And it's not always easy. And going from a trainee to getting a job, it's just so different. I think what Brian was saying earlier is completely correct. You're used to this like match process where you just kind of take it, and that's where I match. I'm going to go. I'm going to do what I got to do. And now you can be a little more thoughtful about it, but you got to be thoughtful about it and really ask yourself, what do you want? And then, seek those opportunities out and have people around you that can help you get to those places.
All very helpful advice as I start the process myself. So I really personally appreciate all of you guys' words of wisdom, and I'm sure those that will watch this and are on the call right now appreciate it as well. So I think I'll go ahead and wrap things up, unless either of you have anything final that you want to share. And thank you both again for giving us your time. It means a lot, and we definitely will probably be harassing both of you in some way in the future.
No, please
Yeah.
do. I've gotten a lot of random emails and phone calls from people I've never met in the last year since I left my first job and made a pretty productive switch, asking how did I do it? How do you find your first job? I am happy to talk to anybody, even if you've never spoken to me before. Look me up on CTSnet, shoot me an email. I'll Zoom with you. We can email back and forth. I'm happy to help any of you guys out there. Just, come to your own truths about what you're looking for and help you make the right decision. If you just need an unbiased ear, to talk to.
Thank you. Thank
I'm
you
sure
so
Josh
much.
is too, even though he's not saying anything.
Yeah, no, I mean, I feel so fortunate to, have trained in the places that I've trained and meet the people that I've met. And so they have been phenomenal to me and shown me how to do that for other people. And so I find a lot of value and, joy in being able to do that. So please, feel free to reach out. I think that's.
Will do. Thank you again, Dr. Boyce and Dr. Mitzman, for your time. I hope you enjoy the rest of your evening, and I'm looking forward to maybe seeing both of you at a meeting one day in the future.
Yeah, absolutely.
All right. Take care. Have a good evening.
Good night.
Good night.